them open. And so what can happen because of that? Pneumonia, which we'll talk about for our third set of slides.
Is my bag in the way?
I don't know, I can't tell.
Which is blood clot that travels through the lungs. Oftentimes, it's not a good result. The only 2 times I've done CPR was on a pulmonary embolus patient that we knew after they died it was pulmonary embolus, but both of them died, unfortunately. Cracked a rib. You had a pulmonary embolus? Really?
Yeah.
And he's here to tell you that, yeah? And there's one lady who's very voluptuous and big girl, and I even
Tupac songs, still alive.
Yeah, yeah, that's what people say. You have to do it right.
No, I heard that.
The other girl was a big girl too, and she had just had a hysterectomy. Yeah. Aspiration. Shock. Why would shock happen? What's shock?
Hypervolemic shock?
Could happen, hypervolemic shock. Decrease in blood pressure causing slowing of blood flow to all the parts of the body. Caused by blood loss, infection, metabolic issues, metabolism issues, and sometimes spinal surgery. Shock is going to happen. Thrombophlebitis, which is blood clots. Wound dehiscence, separation of the wound. Visceration is separation of the wound plus an organ coming out of it. Usually happens on the abdomen. There's really no other place for an organ to be popping out of. Delayed wound healing, hemorrhage, hematomas, weakness, fatigue, functional decline. Constipation, because the swelling of the peristalsis with the anesthesia. Paralytic ileus is absence of bowel sounds because of the absence of peristalsis. Bowel obstruction. Acute urinary retention and infection. Skin breakdown, delirium, stroke are all complications that could happen. Respiratory complications, the atelectasis, pneumonia, hypoxemia in general. We're going to do coughing and deep breathing, teach them the incentive spirometer before preoperatively, giving it to them postoperatively, totally encouraging them to do it. They don't want to do it, they just want to lay there and be bumps on the log because they're exhausted. They had a surgery, they're in pain, they don't want to do it. It's very important to force them to do it. It sounds horrible, but you really want to do it. At least 10 times an hour, the incentive spirometer. And the coughing and deep breathing at least twice or 3 times an hour. Early ambulation is the best thing, but nobody really wants to get the heck out of bed. They don't want to do the incentive spirometer. They're not going to want to get out of bed. But they're out of bed a few hours after the fact, and definitely by the next morning.
How many times coughing? 3, I see?
Coughing and deep breathing 2 to 3 times an hour, and incentive spirometry at least 10 times an hour. I used to tell people to do it 5 to 7 times during every commercial break if they were watching TV. Just so. There's always a clock in the room too, typically, if it works. Just to give them something to, grab the incentive spirometer when commercials come on. When would coughing and deep breathing not be good? Won't it be like contraindicated?
Some type of lung surgery or?
Yeah, do lung surgery, okay. Any abdominal when you don't want the wound to dehisce? People that have had brain surgery or increasing of cranial pressure.
Or like a bypass because they don't want to increase the blood pressure.
Yeah, they're deep breathing without doing the coughing part, right? Right. Eye surgeries with increased intraocular pressure, you're not going to have a cough and deep breathe. And any plastic surgery to delicate tissues, like plastic surgery doesn't have cough and deep breathe to ruin their masterpiece of, new breasts, new lips, new eyebrows, or whatever. Thoracic and abdominal surgeries, we splint the wounds, with a Hug Me Pillow, just hugging ourselves sometimes, they give you the stuffed animals that say the surgeon's name on the t-shirt on the animal. How do you prevent cardiovascular complications? Making sure if they're fluid volume deficient, that they're getting some fluids, and reversely, if they are retaining fluid, that they're getting some diuretics to get rid of some of the fluid. Mobility is really important. Leg exercises, if they're not moving at all, leg exercises are a good idea. Uncontrolled pain leads to increased complications. If somebody's in pain, they're not going to want to move around, they're not going to want to cough and deep. Cardiovascular problems happen 2 to 3 times more frequently when people are in pain. Patient-controlled analgesia is often ordered. Epidural infusions and intrapleural anesthesia, where the catheter is given a local anesthetic. Opioids are going to be the drug of choice immediately post-operatively. They'll be given IV. Eventually, within a day or two, be given orally. And there's some physicians that don't want to send people home on opioids, so they'll start anti-inflammatories like NSAIDs, unfortunately, because pain might not be managed with the NSAIDs. When they're in less pain or their pain is being managed, they're going to be more apt to do the coughing and deep breathing, the NSAIDs proper. Non-pharmacologic methods of pain management, diversion, humor, guided imagery, massaging the opposite side of the body, like if they had a left shoulder surgery, massage the right shoulder, takes, their right shoulder now feels good because you're massaging it. It takes their mind is off of the painful shoulder. Same thing with, if somebody had a below the knee amputation, massaging the other lower leg, it's called contralateral stimulation. It does work. There's a lot of studies that have shown that it works. Encouraging activity, because prolonged inactivity leads to pressure ulcers, DVTs, atelectasis, pneumonia. We want to encourage activity so those things don't happen. Skin assessment, normal wound healing. There's a lot of things that might delay wound healing. Obese clients that smoke, diabetic clients, people with screwed up immune systems, people that look at sunlight, people with poor appetites that don't have vitamin A, B, C, and E, and protein in their diets. So, sometimes anesthesia. One of my mom's surgeries, I'm a Diet Pepsi freak because that's what was in the house. It was high C and Diet Pepsi since I've been a kid. So I like the taste of Diet Pepsi better instead of the sugary high C, I guess, I don't know. But post-op, for one of her surgeries, she couldn't drink Diet Pepsi. Like, she just totally lost the taste for it. So people do, sometimes a couple days, hers was like a forever thing, almost. Complete wound healing, should take, 1 or 2 months. It could take up to 6 months to 2 years, depending on other comorbidities, diabetes, peripheral vascular disease. There's no circulation getting to the area that was operated on. So phase of wound healing, this is sort of a repeat of last semester. The inflammatory phase is anywhere from 1 to 4 days. Blood clots form, the wound becomes edematous, it's warm, phagocytosis is happening, the Pac-Man cells are going to eat away at the dirt and debride the wound. So that's inflammatory, and that's 1 to 4 days. Proliferative is 5 to 20 days. Collagen starts to be formed, and the wound strength gets better, gets stronger. And maturation or remodeling, it's also called, 21 days and beyond. It could take a long time. The collagen fibers that happen in the second phase start to reorganize and form a matrix and tighten up, and hopefully create, or hopefully don't create a scar. You know, hopefully it's a smooth, superficial wound that's not keloidal and puffy. And types of wound healing, first intention is when we closed up right away. Suture, staples, glue. Minimal scarring with first intention. Second intention, when there's a high risk for infection or the wound's infected, or the edges aren't well approximated, the edges aren't together.
What is it? You leave open?
It's open. It's open.
And then heals
Heals on its own. The wound vac is sort of like a way of secondary intention. It's open in that there's a crater, but we're stuffing it with the sponge. And the sponge size eventually gets smaller and smaller when the wound size gets smaller. So that's a form of secondary intention. Tertiary intention or third intention healing is when it's initially left open in hopes to sew it up or to glue it up. And that very seldom happens. But that's, you know, it's a very deep wound. It might be brought together in layers with the multiple layers of suturing going on, like the absorbable suturing and sometimes not absorbable. So it might be resutured and resutures, and you're going to get scarring with that.
Is an example of that, like if somebody has a surgery and they're left open, will the intention to go back in?
Yes, intention to go back in, or intention to
Part of the surgery.
or to suture it up because the infection's gone. Some tertiary wound healing, like the person will be closed by first intention, and then as time goes on, like an infection happens, and they might open it up, put antibiotic beads in it or something like that, and close it up once it's healed. So what are the different nutrients for healing? You know the common ones.
A, B,
Hydration is
C,
super important. Water, vitamin C, vitamin B,
iron, protein.
iron, vitamin K, protein, magnesium, copper, zinc. The main ones, vitamin A, B, and C, protein, hydration, okay?
And
Protein, yes. So, ineffective wound healing, most often between the 5th and 10th days, you can get dehiscence. Partial or complete separation of the outer wound layers, sometimes described as splitting, splitting open of the wound. The sutures might give way, an infection might cause it, a strenuous cough. If you sneeze like me, I can wake up the dead, I sneeze so loud. Like a big strong sneeze could break open these sutures. A nursing intervention for this, which I didn't type on here, I'm sorry. Put the client in low failure, so there's not, there's going to be an abdominal wound typically. So there's not, the pressure's not there. Flex the knees a little bit. Monitor for vital signs. And then dehiscence, not so much as evisceration, but you know, they might need surgery. Evisceration is considered a medical emergency, protrusion of the internal organs through an incision. So that second one's a good picture of evisceration. Oftentimes, skins, any person, I've never had an evisceration, but I've had, dehiscence happen, and they actually, patients always describe it, my wound popped, they say it popped, so they actually feel and hear popping of it opening up. But just think the skin's not opening up, the sutures are what's keeping that skin closed, but they feel and hear a pop. So I can't imagine how scary that would be for a patient, because they usually always freak the heck out, they're like spazzing because this happened. Obese, malnourished people are at high risk for it. Severe pressure on the wounded sutures, elderly are more prone. I had a patient years ago, and she was probably about my size, I guess, and she had coronary artery bypass graft, cabbage, open heart surgery, couple vessels done. And because she was so big, and her boobs were a lot bigger than mine. But when she sat, like her breast came apart, but she couldn't wear a bra. Bra would have been perfect because it would have held everything in together. The dressing was being done twice a day, so we didn't want to use that much tape. She ended up finding like a tube top, like on eBay or something, because it wasn't the time of tube tops might have been in, like they might have been out a couple summers ago or something, but this is back in like the late 90s, so there was no tube tops to be found. But that was like you put in the dressing, and then she had this tube top on. Like I didn't want to ace bandage her boobs, you know, to keep this sucker on, but it's that would have cut off circulation too. But it worked, but she dehisced. Like it was closed at one point, and she actually dehisced staples. So she like usually when you know the staples are healing, you see like up here that's pretend that's a staple, like that's keeping it together. Like this opened up like right away on her. So you know that was super scary, like to have your chest open up. You know, you can think of hip one thing, that's where the most of the time I've had things open up. And she didn't have anything but sternum under there, so there was nothing. And she had internal healing, so you really couldn't see the sternum. You could just see some, like, I guess granulation tissue for the most part. So tell them to avoid straining, hug me pillow if they have to cough. The coughing and deep breathing, we're going to do much better with ambulating around the house, or ambulating around the room or in their hallways in the hospital. Coughing and deep breathing or something in the chest, the abdomen, might not be the best idea. So this is considered a medical emergency, that what you do as a nurse, you get sterile, and sterile might be thrown out the window if you can't find sterile, but saline soaked sterile gauze is the answer, and what you do. And you do that at the same time you're calling for the OR. You might come across, not for this class, because you already did your ATI, but I think for the med-surg ATI during nursing 300, there's an ATI question, like what do you do? And I'm not sure, I can't remember if the answer is put the saline soaked gauze on or call the surgeon. And it's basically, you gotta do them both at the same time. Call for help, maybe the person can call the surgeon while you're getting saline gauze or something, but they're both equally as important. They're gonna have to go to the OR ASAP if they have organs protruding. And it's not up to us to put things back into place. If you put the wet gauze on top of the organ that's protruding, so it doesn't dry out. Bowel can dry out very quickly, and if it does dry out, you can't work with it. Like you gotta cut it out then when it dries out. Okay, drains. Use to permit and encourage escape of body fluids. You don't want to close something up and have this pool of blood in there, because it just lays there stagnant. It's a breeding ground for infection. So drains are used. Complications include hemorrhage, sepsis, bowel herniation, loss of drain, the one type of drain, which isn't on here, but Penrose drain is just a little flexible, very flexible straw-like thing. It's just like a tube that the blood comes out via gravity, and that could be sucked back into the skin. into the body cavity. That can also fall out very easily too, as can the other types of drains. Jackson Press looks like a grenade on the big tube with a grenade on the end. You squeeze it, and then close it, and it actually, the fact that it's called constituting it, and the fact that,
It's negative
when the
pressure.
air- Yeah, the air is like sucking it out, and so when it inflates, it's like pulling the air out. Not horribly like a vacuum, but it's, to take the excess drainage out. There's a bigger one, Jackson Pratt's are for like breast surgeries and small, where there's not that much drainage. And a Hemovac is a much bigger that you can press, and that's like for hips and knees where there's a lot of blood. Make sure the drain is secured. A lot of times you'll see a piece of tape on the actual drain, and the tape is safety pinned to the patient's gown. Bad news, because if you're taking the gown off, you can bring the drain with you. So you just have to be really, really careful. If the drain comes out and it's like post-op day 1 or 2, you gotta call the surgeon, because they're probably gonna wanna put another drain in. And it's not pleasant when they're not under anesthesia putting the drain in. It's not. So I'm observing the function of the drain. Is it working? Make sure it's not kinked. Is it taped correctly? Amount of drainage is sufficient but not excessive. The drain comes out every day. Like the nurse's role is to empty the drain. So you put it in a measuring cup, measure it. Teaching the patient how to do that, because they're gonna have, if they go home with a drain, they're gonna have to measure it too. The goal is that there's less drainage each day. So yesterday there was 40 milliliters of drainage total. Today there's 30, tomorrow there's 20 hopefully, or 30, 30, and then 20. You just don't want more drainage, because that could be there was trauma to the area, or that something internally was damaged and you're just bleeding, or there's an infection, would cause extra bleeding. And note the color consistency if there's any odor. Keep the drain clean and dry, the dressing. Drug therapy to prevent infections. Surgical management of dehiscence. Really nothing surgical, they'll probably just leave it open to air. But the evisceration, they're going to want to put the valve back in. Assess for warm swelling, tenderness, and amount of drainage. Provide a healing environment, and that's really hard. The hospitals aren't the quietest places around. But there's no reason why their door can't be shut. There's a lot of stuff going on in the hallway. Just don't forget about them, you know. The shut door, you think, oh, everything's okay in there. You've got to go in and check on them. Absorb drainage, splinter immobilize, protect the area. Sometimes we'll put a bigger padding on, maybe just not a gauze pad, but they'll put on the bigger abdominal binder pads. Promote homeostasis, promote physical and mental comfort. This is important. The first dressing is always going to get changed by somebody on the surgical team, and remaining sterile is important. The first surgical dressing is sterile. Anything after the first, anything after 7 to 10 days post-op, the wound itself has been colonized with bacteria, not necessarily bacteria that's going to cause infection, but it's been colonized, as they call it, that sterility isn't going to help anything. So sterile products are more expensive than non-sterile products, so there's no need to waste money on doing sterility after the first week to 10 days. You're going to document all these things. Did the patient tolerate it? What did you put on as a dressing? You want to actually put on what you put on. The physician's only going to order what's on the wound and maybe the first layer, like apply Neosporin and a gauze pad. But if it's something deep, you know, it's Neosporin, quite a few gauze pads, maybe cling to fill in the deep wound. Okay, so the physician doesn't have to order every layer. Just maybe the first layer is typically what they would order. pain, post-op patient at the hospital with the GI system. You know, after the respiratory system and pain, GI is probably where the most complications are gonna come from. Nausea and vomiting are common after surgery. Obese people may be more at risk for nausea and vomiting because the anesthesia gets stored in fat cells and adipose tissue and will remain in the body longer. So, you know, instead of, 4 hours post-op, they might be getting sick at 8 and 12 hours post-op too. Assess for the return of peristalsis. It's going to be delayed because of anesthesia. Sometimes people with abdominal surgery, it could take up to 24 hours to come back. Used to be years ago, now, as a new nurse, you weren't allowed to leave until you had poop after a surgery. You had to have a poop. If you didn't poop, you weren't going home. Now, you have to have bowel sounds no matter what you get home. If you had no peristalsis, no bowel sounds, they're worried about you. Why didn't they come back yet? So, surgery centers, I would guess that they have the same mindset of that. You want the anesthesia to wear off, so they don't have more detrimental effects when they go home, when there's nowhere to monitor, because it's an outpatient thing. Paralytic ileus happens, that's when the intestinal wall is hardened and distended and there's no bowel sounds. Very uncomfortable. People might vomit, but they might not be passing gas or having a bowel movement. Constipation is a big problem because of the opioids. Oftentimes they need an NG tube to decompress the stomach, to rest the gut, to allow the lower gut to heal, and provide a route for feedings. That would be later on. Really important with NG tube placement and NG tube suctioning to decompress the stomach, that what we put in to irrigate is actually subtracted from the suction canister to get a true output. You don't want to irrigate it and then keep that in the calculation. So say at 3 p.m. the canister says 150, you irrigate with 60 3 times during your shift, so that equals 180. You want to make sure you subtract that 180 for when you have that total at the end of the night. Okay. I had to crop out the picture of the human on the right-hand side. He had this little sign up saying, "This effing sucks" or something. I don't know, but it was a good picture of the NG tube. These are 2 types of the NG tubes: the Levin tube on the Levin tube on the left, and the Salem sump on the right. Normal color drainage, because it's in the stomach, is going to be greenish yellow, reddish tinge, greenish yellow, would indicate bleeding. Bright red blood is going to be bleeding. Brown drainage is old blood; it just gets old looking, and old blood sort of coagulates and looks like coffee grounds, and that's old bleeding. Suction canisters, red tops typically, these are blue, but different sizes and shapes. The one on the left is 1,000 milliliters, the one on the right is 1,500. It's really important, and I'm sure your clinical instructors told you last semester, if not, they'll tell you this semester. When people have suction set up in the room, it's really important to make sure it's working, because you never know when you're going to need the suction. So this little doodad on the side turns, it's like a little valve that turns, and you'll hear when you turn it. And if it doesn't make that sound, find whoever's closest, the nurse or instructor, CNA, ask them how to connect these tubes properly to the wall, and they'll hook it up. It always sucks when you need suctioning. I didn't even say that. and it's not held up. Because you're only gonna use it in an emergency unless, but post-op patients, anybody can need it. If somebody had a stroke and they're choking on their vomit or something, you need it set up. So make that a point this weekend. You're at it. Color, consistency, amount of drainage every 8 hours. Sometimes there's like internal flexible plastic things to take out. There's nothing more gross than family members coming in and looking at this greenish, yellowish, reddish, brownish drainage. I've actually put pillowcases over top of them before. It's just not pleasant for family to come and look at, I think. But they can be empty too. So, you can take out the inner plastic and dump that down the toilet, not in the sink. And start fresh. Yeah.
You ever use they use them on female patients for incontinence, like especially overnight. Instead of them getting on a bedpan or getting out of bed, they have like it's almost like a hot dog looking thing, almost kind of like that. And it goes kind of like in the little V area right up against the vagina, and it just has suction.
The urethra.
Yeah, but it just sits right up against it, and then they suction it right into those.
Yeah.
Do you use them?
They're new. They're new in the last couple of years.
Love them. They are
It's
awesome.
a wonderful. Hopefully the person's a millionaire. They didn't
I can bring one in. They're pretty cool.
Yeah, I think Miss Frank talked about it. I think that last semester.
I'll bring a used one in, so that way it's not stamped.
Yeah, but it's like a little mini maxi pad, really.
Yeah.
It's sop it up. It's cottony.
Yeah, it's awesome. Yeah, it got to be placed right. If they're moving around constantly, it's not going to
So if
work.
somebody's sort of bed bound and not really movable, they're great.
Yeah. You use them.
And they're external, so the risk for infection is very slim. So this is the formula I talked about earlier. Drainage in the container minus what you put in as an irrigant is your true drainage. Intestinal obstruction. You'll usually see it 3 to 5 days post-op. Pain, shorter intervals between bouts of pain. Bowel sounds are very hyperactive. They vomit. Their belly is like a basketball, very distended. Hiccups, no BMs. You put an enema in and you're not getting anything out, not even brown tinged, because the obstruction is so, whether it's a stool or not is another thing, but the obstruction, there's a kink, so it's not getting, what?
May vomit fecal matter. That's what I remember. I told you about the lady that her breath smelled so bad. That's it.
You are having fight of ideas, my friend.
No, I'm serious. No, you guys. I know you guys heard me say it. Yes, I thought she had such a bad impaction that when she talked, it smelled like poop. That just.
So they may vomit fecal matter, because there's an obstruction, it has to come out somewhere, and it's there. There we go. I had a patient in a nursing home with students years and years ago who had such rotten teeth that I thought she had poop in her mouth. And her family, for some reason, refused to see a dentist. But her teeth were rotten, and it smelled like she had poop. Because I kept, I checked her. Me and the students went in the bathroom. I said, she has a load of poop, but we gotta go check her diaper. Nothing. Wasn't even passing gas. And then it wasn't until like later in the day, I'm like, what a dumbass. It's her teeth are rotten.
I'm sorry. I did
Has me died.
for a couple of years now, and it's
So an obstruction is a blockage of the intestinal passageway somewhere. Tumor, inflammation, adhesions, a big stool, kinked intestines, lower abdominal surgery, childhood illness, we talked about absence bowel sounds, abdominal discomfort, abdominal girth, which is the measurement of the, the belly so distended that we're measuring the girth, like at the point of the umbilicus, to see if their girth is growing. May vomit feces again, and G-tube to suction, IV fluids, NPO, walking around to get the peristalsis, to get the blood flowing, and hopefully they can pass gas and eventually, poop.
Knock that sucker loose.
Teaching, prevention of infection, hand washing, teach them how to do their own wound care, teaching family members how to do wound care, teaching about nutrition for wound care, teaching about nutrition just for healing, pain and medication management, progressive increase in activity level, use of proper biomechanics, follow up with the PCP. So what kind of things are we going to assess? Vital signs, their neurologic status.
For what, bowels or just?
This is everything in general, this is the last slide.
Oh.
Everything in general that we're assessing postoperatively. Neurologic assessment, we're comparing to their neuro assessment preoperatively.
Respiratory,
But respiratory rate, their depth of breathing,
cardiac,
their O2 sats, vital signs,
cardiac,
output, urine output, pain. Actions, what's the nurse gonna do? Closely monitor, from the PACU to the floor. If they were in for a scheduled surgery, you're either gonna start the admission assessment, because they're being admitted to the hospital now. Continuous monitoring of the patient's status, Medicaid for nausea and pain. Teaching family care, tell the family about the visiting hours, tell them, give them updates when the patient, if the patient's not back from the PACU yet. Provide discharge instructions if the family members are present. Make sure the family's involved. And with HIPAA, that used to be a problem when HIPAA first came into play. Like, we had to get the patient's permission for the family member, to be in the room with the discharge teaching. Maybe it's a distant family member, maybe it's not somebody they're going home with, so why they need to know about the post-op, why they need to know about the discharge instructions. So, it's always a nice thing to ask that, is it okay if I talk about your care in front of your family member, or is it okay? Sometimes it might not be a family member, it might be a neighbor who's just nosy and came to visit, honestly. That is that. And now we have pneumonia. So let's take a break because I'm gonna start losing people.